Hello, colleagues. Here's hoping that everyone is thriving at the start of this new year. My name is Chris Parker, and I am the Director of Population and Global Health at the Georgia Health Policy Center, Georgia State University. Today, though, I come to you as the Facilitator-in-Chief of the Georgia Comprehensive Cancer Control Consortium, and it is my pleasure to introduce its co-chair, Dr. Jim Hotz, to make his remarks here at this summit. If Jim were making his own introduction, he would probably lead with the fact that he is a ride or die Buckeye, and not so much the important details of him being a co-founder of the Albany Area Primary Healthcare Community Health Center, and now is currently in the position of Clinical Services Director. He would likely understate his acclaim and notoriety in Southwest Georgia, where he has practiced all of his post-resident years. He's an honorable man, well, mostly, and here are just a few of his badges of honor. He's the Associate Clinical Professor at Mercer University. He served as board chair at the Phoebe Putney Memorial Hospital, the Georgia Association of Primary Care, the National Association of Community Health Centers, Horizons. He's a member of the National Colorectal Cancer Roundtable and co-chair of the Community Health Center Task Group. Given his time in the National Health Service Corps, it isn't really a wonder that he has dedicated his life to serve people. This life of service is the kind of stuff that movies are made of. And there is a rumor that there is in fact a movie character his life inspired. He will probably not mention that either. Always reading, he's published many scholarly papers and is passionate about cancer screening and disparities. And so it is my pleasure to invite to the podium, such as it is, my friend, the good-natured, bright, and driven rural health campaigner, co-chair of the GC3 steering team, and lead of the early detection and screening work group. Please welcome Dr. Jim Hotz.
Thank you, Chris, for that very kind introduction. And I would like to thank Winship Cancer Institute for hosting this Cancer Summit, especially Dr. Ramalingam, its director, Dr. Gillespie, and Denise Ballard. And what I'd like to take you today is on a 2-decade journey. I've been the co-chair of GC3, Georgia Cancer Control Consortium, for the past 20 years, and I'd like to take you on this journey. We've been blown off course by COVID and a few other challenges, but the destination remains the same. We'd like Georgia to be #1 in cancer control in the nation. This journey started with this gentleman here, Hambleton Jordan. He's an Albany native, my hometown as well, White House Chief of Staff under Jimmy Carter, and a 4-time cancer survivor who eventually lost his battle with cancer. And he had many contributions to cancer control in the state, but his signature contribution was accomplished when he was leading members of Georgia's General Assembly, the medical community, public-spirited citizens to consider ways to spend Georgia's $5 billion tobacco settlement as part of the master settlement. And in 2001, this group decided to start the Georgia Cancer Coalition, whose mission was to make Georgia the national leader in cancer prevention, treatment, and research. The mission was also, as you can see here, to reduce the number of cancer-related deaths in Georgia. Goals: prevent cancer detected early, provide quality care for all Georgians, establish collaborative process to address cancer data and metrics, build Georgia's reputation as a place to do cancer research, and generate a combination of state, federal, and private funds to support cancer, with the investment capital initially coming from the master settlement. But it's been a bumpy road since, as all public projects are. We had the state cancer plan revision driven by IOM. They actually had an IOM report that said, if you want to be a national leader, how do you measure it? We had 52 metrics to do that, got reconfigured under that. We had a lot of state agency changes through this time and changes in government. We had revisions of the plan that have gone on, 4 revisions, all the way up to the one that's looking at targeted cancers and equity. We had a big recession that took funding out of tobacco settlement. Health reform, we anticipated we'd be getting Medicaid expansion, didn't get it, then we had to look at revising plans to look at health disparity reduction. So there's been bumps along the way. The latest was the pandemic, a 100-year pandemic, changed quality metrics across the board. Cancer hit particularly hard. Our initial vision was to use tobacco settlement dollars as venture capital. And in 2002, we invested actually $62 million of 172, or 36%, developing some key infrastructure I'll talk about later. Through the various bumps along the road, that funding has decreased. In 2019 was 14 million of 150 million, or 9%. That initial $5 billion that we thought would run out after 25 years now is going to be there forever. So what we had to do is some shifting. Our initial structure was the Georgia Cancer Coalition. And then underneath that, we had Georgia Core, which still exists today, very strong. We had a bunch of distinguished scholars coming into the state. We had regional cancer coalitions, had a biorepository, very key infrastructure pieces were built in. And as we lost funding for the GCC, we evolved into what we currently have, which is Georgia Cancer Control Consortium. And in that consortium, it's made up of a series of groups. This thing is being led up and driven by Georgia State Health Policy Center. Dr. Chris Parker gets funding from the DPH and CDC grant that comes to them, and tremendous support across the board from the American Cancer Society. We start out with prevention. HPV is a big part of prevention, along with tobacco control. We have early detection and screening section, which breaks off into branches on prostate, colorectal, lung cancer, and we have a breast and cervical branch, and we're looking at developing a roundtable with that. In addition to that, we have a diagnosis and staging treatment group, a survivorship group, and a palliative care group, and then a way to do data and evaluation. Leaders of those groups are here today. We're going into breakout groups. You can look at ways of saying how we need to overcome the pandemic and change the current plan or modify it, and also look at groups that you can join. And I really encourage everybody to look at a group to join. What have we accomplished along the way? Well, we've increased our HPV vaccination rates, actually reducing cervical cancer. Our Commission on Cancer Centers throughout the state, and there's 36 of them. All of them now have palliative care. Our Lung Cancer Alliance says we now have 33 lung cancer centers. When we first started the plan, there were none. We were the first to have a cancer roundtable. We thought initially by 2019 we'd have 4 lung cancer screening programs. We had 33. In June of 2017, we had a goal of 95% of Commission on Cancer Centers to be part of rapid quality reporting, so all their SEER data is reported electronically. Initially, when we started in 2013 plan, there were none. We were one of the beta test sites nationally and now have 95% reporting. We developed the first NCI Comprehensive Cancer Center in Winship. Through these efforts, we have regional coalitions that now cover every county in the state to be able to take this cancer control plan and take it down to the grassroots. Georgia Core has brought in numerous clinical trials and other research, including the CDC Colorectal Cancer Project, which brings in almost $5 million over 5 years for cancer control. And we brought in over 200 distinguished scholars, many of whom remain in the state today. But here are the facts today. Still, Georgia remains the second leading cause of death, and it's the most feared chronic disease. There are 10,700,000 Georgians in 2020 census, but of those, there are 5% of the population are cancer survivors. ACS estimates there'll be 58,000 new cancer cases and 17,000 deaths this year. Cervical cancer can be eliminated. We can eliminate a cancer to get our HPV vaccination rates up to 80%. Lung and colon cancer still remains our two leading cancers, followed by breast and cervical and prostate. That's why in the plan there are 5 big cancers: breast, cervical, colon, lung, and prostate. Black males still have 19% more likely to die than white males from cancer, and Black females 9% more. So the bottom line is that in 2021, 0.5% of our population will get cancer. 5% have cancer and are surviving it. And there's 10 million people that don't want to get cancer. One is preventing, catch it early. So this is a plan for all Georgians. So here's where we are today with the Georgia Cancer Coalition. We have our mission to save lives, reduce burden of cancer, remove disparities. Priority areas, as we mentioned earlier: HPV and prevention, detect them early, treat them right, facilitate palliative care and support, improve quality of life. It's a coalition of the willing, 200 volunteers and agencies who recognize that failing to plan is planning to fail. And this is where all the planning comes together. So we have some guiding principles of the plan revision. It's got to be equity. We don't want to leave anybody behind. We got to do translational research. Colon cancer screening was first detected by Jack Mendel, showing that in 1993, you could do a quiet test and reduce cancer deaths significantly. 25 years later, national screening rates were under 65%, with a goal being 80%. We can't wait 25 years for lung cancer screening to get out to 80%. And we want all of our cancer screening rates to be over 80%. We've got to communicate to Georgians what they need to know about cancer prevention, awareness, detection, and how to get involved in research and clinical trials. We need to advocate for funding. We need to get tobacco settlement dollars back in and find other sources. There's national funding that we want to drive into Georgia. And then we want to do surveillance. We want to make certain that our metrics are best. We had an IOM report in 2005 that said the 52 things that could tell you to reach number one. We want metrics to actually show that we've been there. And what we want everybody to know is you can be part of this plan. But this pandemic has been a big bump in the road. There's been a sharp decline in screening. March through May, there was a decline in screening of 90% in breast, 79% in colon, 63% in prostate. Absolute decrease in screening due to the pandemic: 3.9 million in breast, 3.8 million in colorectal, 1.6 million in prostate. NCI estimates there's going to be 5,000 additional deaths in breast cancer and 4,000 in colon cancer just from this decrease in screening. This was throughout the nation. Northeast got the sharpest initially. And interestingly enough, all socioeconomic spectrum was hit, and the highest actually had one of the biggest drops in screening rates. But if we look at our poorest and our health disparities, UDS, or the Uniform Data System, which is reporting all 30 million community health centers, cervical cancer dropped over 5%. Colorectal cancer screening dropped 5%, almost 5.5%. We went back to where we were in 2016. We dropped back 5 years in screening. Tobacco use screening went down. So we know that everybody's been hit by this bump in the road. And what we need you to do today is to help Georgia get back on course. We need you to help volunteer to join one of these groups. We need to overcome the decrease in vaccination, tobacco control efforts, the delay in cancer detection and screening, delay in cancer treatment, decrease enrollment in cancer research and clinical trials, the additional stress on survivors, palliative challenges, and the decreased investment in cancer control. So your opportunity today is going to be to join one of these groups, to go into the breakout group, to contribute to the plan that we're doing and help see if we have to modify the plan, and also to become part of the GC3. We welcome you to join. We need your efforts, and together working, we can get Georgia back on its course to become #1 in the nation in cancer control. Thank you very much for your time, and I'll turn it back to you.
So
Good morning, everyone. I am Chris Parker, Director of Population and Global Health at the Georgia Health Policy Center. As I indicated previously in my introduction of Dr. Hotz, who is the head cook and bottle washer in some ways of all things cancer control in the state. I like to say he's actually one of the co-chairs for the Georgia Comprehensive Cancer Control Consortium, or the Georgia Cancer Control Consortium, we indicate as GC3. I'm kind of taking a little bit of time just to give folks the opportunity to join us and then to kind of get started with this Q&A. I'm watching the count, and we are still increasing in the number of participants. And I want to give folks an opportunity to, as they join, reflect on what you've just heard presented by Dr. Hotz, and ask that if you do in fact have questions, that you go ahead and submit those questions in the Q&A and not the chat. So let me just take a brief moment to give you that opportunity to organize your thoughts and to submit those questions at this time. Dr. Hotz, welcome to this round of questioning, given what we've just heard. I wondered if there was anything you wanted to underscore really quickly, just to allow folks the time and the opportunity to get their questions in. About having been blown off course, how do we correct things to kind of get back into the kind of cancer control that we would want to see happen here in the state of Georgia?
Well, thanks, Chris. One of the most important things when we're doing, collaborative efforts is to make certain we have an aspirational goal, something that brings us together. And if you remember the beginning of my talk, I basically showed Hamilton Jordan, and the vision was to make Georgia #1 in cancer control in the nation, something we can do. What I am most disappointed about, I was having my slides, I was going to put in there, just like Georgia is #1 in the nation in football, we'd like to be #1 in cancer control. But I didn't have enough belief in Georgia's ability to beat Alabama to do that. But how do teams like Georgia accomplish such a lofty goal to become #1? It's because they have an aspiration to do so. They know it's important. Now, what we're doing is a heck of a lot more important than winning football games. It's saving lives. There are thousands of people who die of cancer who don't need to die if we just applied the technologies that have been on the shelf for years. Colorectal cancer screening, Jack Mendel in 1993 showed that we could significantly reduce colon cancer deaths by over 40% by just doing Guaiac test every 2 years. Now with FIT test and colonoscopy, we can punch that number to 80%. There are a lot of very achievable goals, but it does require having a plan. It requires participation, and it requires enthusiasm to do that. We can get distracted by events of life. And COVID is one of those unexpected 100-year events that have taken us all off course. So I think what we'd like to do now is a recommitment to getting our act together, to getting in the huddle, to doing the planning, to doing the work locally. Like a good football team, everybody has an assignment, block the guy in front of you, take care of your community, and we work collaboratively to get Georgia moving on that goal to be #1 in cancer control. I think you're muted, Chris.
I appreciate that. I was just saying, once again, I'd like to invite folks to use the Q&A to get your questions. I do see one here. It says, thanks for being a stalwart. This is from Dr. Ramalingam in reducing cancer burden in Georgia. Can you please discuss the major barriers to cancer screening as you see it?
Well, there are a series of barriers that are, classically recognized. The most common reason given by people to say why I did not get colon cancer screening or lung cancer screening, the most common reason given is my doctor never told me. Okay. The most common reason people say why they got screened is my doctor told me. So what we do know is in those primary care practices, the physician practices, and the public health arenas, an active educational campaign. When people are coming in to see you, let them know they need to be screened. We also know that an active outreach, and these are evidence-based programs that we're actually doing in a CDC clinical trial down here. If you actually outreach and go get people to bring them in and let them know they're due. So there's an educational barrier. There's an economic barrier. We know that there are people who cannot afford this colonoscopy. And one of the things we do with the colorectal program that the CDC sponsored is find ways to overcome the financial barrier of a colonoscopy. The breast and cervical program is an ideal example. My group alone did over 370 breast and cervical programs, and this is throughout the state. All the district health departments do this. So the economic barriers, the attention to the detail barrier, and now with COVID, the disconnect with the system. If you looked in my slides, we did not just go down in cancer screening. Our hypertension control rates went down. Our diabetic control rates went down. So, we know there's recognized barriers to care. You have to have an organized, healthcare practices. You need to remove economic barriers. And we do know, especially people who suffer adverse social determinants, we know that there's power in navigation. For over 20 years now, we know that if you navigate a positive mammogram, in Harlem, this was done, they found that the stage of disease and the outcomes are significantly better. If you give a fit test to somebody, a fecal chemical test, in our project down here, we've shown that the return rate is 30%, but if you, use like our Horizons community solutions and you bug people to get it back on average of 5 calls, we know that you can get an 80% return rate. We know if we send somebody the positive fit to get a colonoscopy, if we have a navigator, we can get a show rate of 95%, and that's on rural, poor, uninsured people. Yeah. So we know there's mechanisms of overcoming barriers that are economic, educational, organizational, and social determinants driven. And what we're trying to do with this session here and this meeting is to say, let's get together, let's get back, to putting our best team out there and use the evidence-based interventions we can to overcome these barriers to care. It's a very good question, and it's one of our great challenges we have in the state, and that's one of the reasons we have GC3 is to come together and discuss how we overcome barriers throughout the state.
Yeah. Thank you, sir. So there are 3 more questions here, and I'm going to ask maybe, if we do the almost elevator answers, just to ensure that we get through them in the time that we have, which is about 6 minutes. So Lynn says your presentation was wonderful, best things in sliced bread. She doesn't actually say that, but says that you gave really good insights into the state's investment in cancer control over the last 20 years and the kind of ebbs and flows of that. What message would you have for state legislators about the importance of funding cancer control initiatives?
Well, the money for tobacco settlement dollars are always going to be there. We thought it was going to sunset in 25. It's not. It's significant. And if you ask the average citizen in healthcare what they fear most, it's cancer. We had a vision to invest that in a comprehensive cancer control effort. And, we've backed away from that vision. At a time in which we have surpluses in budget and we're figuring out how to spend, I think one of the ideas that, we would put out there is let's reinvest in this, this concept of taking tobacco settlement dollars that are there to mitigate the impact of cigarettes on the state, and let's reinvest them in critical areas to remove barriers, to push awareness, to invest in that infrastructure. Georgia Core is a piece of that. Our regional cancer coalitions are part of that. So we have already that infrastructure. We invested in clinical scholars to bring them in. Let's get back to doing the great things we did to push us back to be number one, not just in football, but in cancer control.
Yeah, I love it. Thanks. So there's a question about telehealth and its role in addressing cancer screening. Can you say a little bit about how we might do that here in Georgia? If it's already been done, your thoughts about how we could do better?
On what was the first part of that?
Telehealth. Using
Telehealth.
telehealth for cancer screening.
Yeah, great question. What we have found during the height of the pandemic that, you can reach people through telehealth. So, for like scheduling a mammogram can be done all through telehealth. We can connect to people. I spent about a month in my basement doing telehealth and was able to connect with 98% of my patients. Actually had better control of my show rate. So we know it's a great vehicle to get out to folks, to reconnect them. For colon cancer screening, you can call them up, send them out a fit and tell them it's important and make certain they send it back in, and you can arrange the screening. So it's a great way to connect with people, especially rural people, poor people where transportation's an issue. So what we found, it is a tremendous new tool. And during the pandemic, the restrictions on telehealth have been lifted. So I think it's a great concept, great idea, and something that, we probably should research and explore more.
Yeah. And the last question I have here is from Al, who's wondering how the GC3 might be the kind of clarion call around statewide communications with regards to cancer control. Can you say what vision the GC3 might have for being in that role of kind of bringing everybody to that place of understanding and action?
Yeah, and I think it's real important for people to re-engage in a planning effort. Failing to plan is planning to fail. And, at a time like this where we've been disconnected, and now that we have the ability to connect with Zoom and other things, we really have an opportunity to connect in a way that we've never done before. We've done a cancer summit every year since the cancer plan's coming out. This is the largest attendance we've ever had, and I really thank Winship for putting this together. So we do know that not only telehealth is a way to connect people to their doctor, Zoom and these connection platforms we now have available are a way of connecting the state. We have over 200 people who've said they'd sign up, and I encourage everybody on the call today, find a place to participate in the cancer plan. If you're involved in healthcare and cancer is one of our biggest issues, sign up. We need your volunteer and your help to get us back on the road to number one.
Well, thank you so much, Dr. Hotz, for being here. We do have 2 minutes. I do have a little bit more detail to provide to folks in terms of what happens next. Let me just check in to see if there are any remaining questions that folks who have showed up to have this conversation with us today, if you have, please go ahead and put it in the chat or the Q&A just now. As you're doing that, or if you choose to do that, let me just declare that once we're done here, the next speaker up will be Dr. Brian Rivers, who will be our keynote. And so I invite you to kind of head back to the lobby and get back into the main theater to be able to participate there. I also invite you to complete the evaluation forms. If you go back to the lobby, there's a yellow button. I think it's at the bottom right of all of the yellow buttons. You'll be taken to a form that will allow you to do that. So please, please, please do that. And the last thing I'll say before just thanking Dr. Hotz again is if you want to sign up, there are many ways to do that. For those of you who are here today, the Health Policy Center is in the role of facilitating all of the work groups and the steering team. If you want to pop me a note at Chris Parker at gsu.edu, GSU meaning Georgia State University, just saying, hey, I have some questions or I have an interest, please don't hesitate to do that. Dr. Hotz, thank you, sir, for all that you do and for this time together. Everyone, have a wonderful weekend and continue to enjoy the summit.